Okay, hello. I'm opening up this PowerPoint now. It'll cooperate with me. Looks like. Can you see the screen?
It's coming up. We can now. Yep.
You can't see it? Okay.
We can. Yeah.
All right, so hello everyone. I am Tiffany Rush Wilson. I'm the Associate Department Chair of this department, and I'll be presenting with two awesome researchers, Susie Schnell and Rebecca Witkowski. And this is not the right PowerPoint because your name didn't change. She has two C's in her name. Sorry about that. And what we will do is tell you a little bit about us and our interests and how we came to do this work, and then we'll get started. So eating disorders has been my professional specialty area throughout the entirety of my career. I decided I wanted to specialize in eating disorders when I was in the 11th grade. So I know a lot about this and hopefully a moderate amount about other things too, but this is one area that I know pretty well. In order to get some of the research and information about substance abuse, I have a person with whom I work in my private practice who also works for the Cleveland Rape Crisis Center and for a substance abuse center in the area. And she allowed me to interview her and get some of the information I needed for that particular part of the presentation that I wrote. And then Susie and Rebecca, let us know a little bit about your interest.
Well, I've been interested in that's what I want to do. I want to work with individuals with eating disorders just from overcoming one myself and just really interested in how it occurs and all the factors that play into it. And I just really want to be able to work with those who are suffering and see them, hopefully get better and help them through that process. So very happy to join Dr. TRW and Susie for this presentation.
For me, I actually have no personal experience with either disorder, but I'm recognizing in my research for using photography through personal expression as an intervention tool that both of these disorders are really kind of affect all populations and cultures. And it's prevalent in social media in almost every aspect of my research. So it's something that I really feel like that it's worthwhile getting to know more about. And it's kind of I was very honored to be a part of this presentation. So that's pretty much all there is for me.
What I'm going to ask all of you who are in the audience to do is please speak up when we have some interactive things to discuss. There'll be times where one of us may pose questions back to you, and I know you don't have your cameras on, but please feel free to unmute your microphones and join in during the discussion pieces of the presentation. So overview and purpose. Everybody eats, everybody drinks. At least I hope everybody eats and everybody drinks. And a lot of us take medications or different substances for various specific indicated reasons. They have a lot of functions. To eat and to drink, we need to live. To take medications, we are making an effort to be healthy and ensure our own functioning. Reduce pain, do those things that make life more bearable and livable for many people. These are also things that are related to social functioning to different degrees. So when people think about celebrations, there's often food there. For a birthday, we have cake and there's punch and ice cream. And for celebrations, sometimes there's alcohol involved. We do these things to engage with other people, and sometimes we need even the medications or the substances in order to alleviate the pain that comes along with some people who have chronic pain and different injuries and illnesses in order to engage. One of the clients I'm working with right now has to have medication in order just to really sit up straight. She's got such severe chronic back pain that without her medication, she can't move. So for her, eating and drinking are life-sustaining, and the way she sees it, her medication is also life-sustaining. So the focus on this presentation is not just on simple nutrition or, simple drug use, but complex intakes that are related to pathology and extreme. And by simple, I mean non-complicated presentation. So simple nutrition is just the idea of eating. Eating disorders are more complicated than that because it's not just about eating. There's all kinds of meaning and thought and process involved in simple, what seems like simple intake for many people. During my doctoral degree studies, one of my professors, who was probably really not my favorite professor at all, told me that it would be really simple if I just told them to eat. I was thinking, wow, eating this anorexia nervosa in particular, the illness that he was referencing, it exists under the present criteria since the late 1800s or so. And I think since that time, somebody would have thought to tell somebody to just eat and have it work if that was the simple solution. But it's much more complicated than that. What he did inform me of by his response, however, was that for someone who is not well versed in the thinking that comes along with eating disorders and has no exposure to them, they haven't thought about what it feels like to be in that position, the idea of just eating does really make sense. If you are hungry, if you are starving, if food is available to you or readily available to you, then you just eat it. But if there is a complicated psychology attached to that, different meanings, coping, other pieces of the eating relationship, then just eating doesn't make sense. It's almost as simple as if someone drinks alcohol and they don't like the effects, they can just stop. Not everyone can just stop consuming substances. Not everyone can just simply move on with their lives and not think about it again. It's a much more complex relationship. So, hopefully you've already done this. Think a little bit about eating and about drinking. Think about the things that come to mind just for you. Anything come to mind for anybody in particular? See? Nobody here eats or drinks?
Dr. Rush Wilson, the first thing that came to my mind is enjoyment.
Okay. Any particular food or beverage come to mind for you?
Coffee.
Coffee. Okay.
Mine is comfort. Food has become a comfort for me. Sweet stuff.
Particularly the sweet stuff. Okay.
Just feeling hungry.
Feeling it in my hips.
Okay. Giovanni, did you say something?
Just feeling hungry physically, and just naturally the response is, well, it's time to put food in my mouth, and so I'm not hungry.
Mm-hmm. Okay, so food is more mechanical sometimes, or the process of eating. It's interesting. I'm looking at the time too. I'm in Eastern time, so it's 12:09, and almost every time I do these presentations, it seems like they happen right at lunchtime. So when I ask that question, it's actually a nice reminder to people that they probably are not eating during the time when we typically do eat, because eating becomes routine. And eating can become such a huge career for some people. For instance, the last book I bought was on the history of the American meal planning, and how in the United States we decided that meals came at 3 particular times, and what the history and origin is of that. I'm pretty sure the average person doesn't pick that up as just their regular reading, because they really care about why we eat at these 3 distinguished or distinct times during the day. And when I think of eating and drinking, I usually think of pineapples. They make me very happy.
Dr. Rush Wilson, there is actually a comment in the chat box, and it's from Allison, and she is a recovering anorexic for years, and she still thinks about guilt. And then she says, I find the strength to avoid my symptoms.
Awesome. Thank you for sharing that. And here's another thing that I'd like to share before we move forward, and may have it listed, or one of us may have listed it in the presentation. People who are interested in eating disorders and in substance abuse, not always, but very often, have their own personal histories and stories that they can contribute. I have a personal history of having particularly bulimia nervosa, that I had as a result of my parents, and I smile thinking about it because it made me so angry at the time. My parents would not allow me to have anorexia. They actually actively told me I couldn't. And that's a really strange conversation looking back at it now, but it was meaningful at the time. So I understand the idea that the guilt can be associated with thinking about food because there's such a history and a story and a path that many people have related to eating. With respect to substance abuse, I don't have that history, but I have someone very close to me who does have that history, and they have the same types of reactions when thinking about drinking, particularly consuming alcohol. So the point is that many people have simple relationships with food and drink. A lot of people don't. So some people can stop eating when they are no longer hungry. They can stop engaging in alcohol if they choose not to. They can stop at their points of satiety. They can engage in alcohol and substance use recreationally, and they can control their use if they want to. Social functioning and expectations highlight our role of food and drink, and it can be really simple for some people, particularly difficult for others. We have a lot of information on some of these slides, but generally, and you can learn this through coursework too, we're talking a little bit here about substance-related disorders. There are 10 separate classes of drugs that are taken directly from the DSM, and we're talking specifically about alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, stimulants, tobacco, and other substances. Right now, there's so much information in the media, particularly about the use and the legislation of opioids and cannabis. So if that is an interest of yours, please continue to watch the news. Even today, there was more movement in the Senate around the use of opioids in particular. And with addictive and substance-related disorders, we learn about tolerance, about withdrawal, and about the things that come with the active adjustment of our brains and how our brains respond to information based on our intake of these types of substances, legal or not, whether they are prescription or not. They are taken into the brain and processed in particular ways. Okay. You want to do this one?
So, what are eating disorders, guys? Well, it's a persistent disturbance of eating or eating-related behavior. It can result in altered consumption or absorption of food, so restriction, binging, so forth. It can significantly impair physical health or psychosocial functioning. For example, those suffering from anorexia nervosa are so malnourished that when it gets so severe that they have to be hospitalized, and their heart is just not beating as fast, and also a lot of risks for osteoporosis and all of that. Bulimia is the same. There can be the throat starts to deteriorate, heart problems, all of these other things that people that are suffering from really, it doesn't even occur to them what's happening to their body. There are 6 different disorders in the category. There's pica, which is eating non-food substances, rumination disorder, avoidant, restrictive food intake disorder, anorexia nervosa, bulimia nervosa, and binge eating disorder. And there is post-stress onset for some.
There's a history to eating disorders. Let's read everything. Anorexia nervosa and bulimia nervosa are the oldest two, with anorexia by far being the oldest of the eating disorders. It's been around with its current criteria since around the 1870s. And the word anorexia itself means lack of hunger. Nervosa always means due to nerves. With bulimia nervosa, bulimia means ox hunger. Nervosa still means due to nerves. With anorexia nervosa, it's a pretty rare condition to have, but it can be quite lethal. So when someone is diagnosed with anorexia nervosa, with its full criteria, they have to have medical and psychiatric engagement in order to get through the illness in most cases. The longer a person has it, the more difficult and persistent the disorder can become, and the more likely it is to be lethal. Bulimia nervosa used to be a subset of anorexia nervosa until around 1980 when the DSM-3 was published, when a physician named Gerald Russell noticed that these people with anorexia nervosa, they don't lose weight at the same rate, and they're purging their food more often by vomiting or by over-exercising, or they're doing something to get rid of the food, but for some reason their weight's a little bit different and treating them is a little bit different. So at that point, the diagnosis was separated into two. So bulimia nervosa is separate. It is not quite as lethal as anorexia nervosa, but also can be lethal. People use various methods to engage in what is called inappropriate compensatory behaviors, or inappropriate ways to manage their food intake when they don't want to keep the food down, from vomiting to syrup of ipecac to laxative use and many, many other quite honestly creative, for lack of a better term, but dangerous ways of managing the disorder. There are some other eating disorders too that have shorter histories, some official, some that are not. And Rebecca will talk about diagnostically what those are. But there are a couple, orthorexia nervosa we mentioned, and diabulimia. Those are not in the DSM-5, but they are ways in which people have manipulated food and fall under the eating disorder range.
So anorexia nervosa these are the descriptions. The restriction of energy intake relative to requirements that leads to a significantly low body weight in the context of their age, sex, developmental trajectory, and physical health. Significantly low weight is defined as a weight that is less than minimally normal for children, adolescents. There is an intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain even when they are very thin. Disturbance in the way in which one's body weight or shape is experienced. For example, say a woman is 80 pounds when she's like 5'5", but she sees herself in the mirror as being overweight. So there's two different subtypes. There's the restriction type. So in the last 3 months, the individual has not engaged in recurrent episodes of binge or purge eating behavior. And then there's the binge eating purging type, where the individual engages in recurrent episodes of binge eating and purging, self-induced vomiting, laxatives, diuretics, etc. So they categorize the severity based on BMI. And a normal BMI is usually from about 18.5 is on the low side to that's like 22, 23. So mild is when the BMI is still greater than 17. Moderate is 16. 19, I believe that says. Severe is 15 to 18.99, and extreme is below 15. The mortality rate of anorexia nervosa is one of the highest, with 5% per decade. And also medical complications and suicide play into that as well. And then bulimia nervosa is recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time an amount of food that is larger than most people would eat in a similar period of time. So, for example, not just like a big meal like you would eat on Thanksgiving, but like just like almost, it can be anything to like a whole day's worth of food. I'm just reflecting back because I used to suffer from bulimia nervosa as well, and it is like a very large amount of food. I remember when I would binge eat, it would be well over the amount of calories that I would eat in a day. Um, and then there's a sense of lack of control of overeating during the episode. For example, not being able to stop, and also um, reflecting back on myself, I remember I would try to have people interrupt me in the middle so I would stop the behavior, but there's just kind of like once you're so far into eating, there's just no stopping, like it's going to happen. The compensatory behaviors after are going to happen. Also, so with the binge eating, there's the behaviors after to prevent the weight gain, such as self-induced vomiting, laxatives, diuretics, other medications, excessive exercise, fasting for the next day. This behavior will occur on average at least once per week for 3 months to be diagnosed, so to speak. The self-evaluation is unduly influenced by body shape and weight. The individuals that suffer from bulimia are usually appear to be a normal weight, so it's very hard to, which is unlike anorexia, whereas the individual is significantly underweight. To be categorized as bulimia does not occur exclusively during episodes of anorexia, and the mortality rate 2% per decade. The prevalence is 1 to 1.5 in young females.
We had anorexia nervosa and bulimia nervosa in the DSM for years as the eating disorders, and then we now have binge eating disorder too. Binge eating disorder looks a lot like anorexia nervosa and bulimia nervosa, but there is no inappropriate compensatory behavior. So the criteria are still listed here, but the thing to take away, and of course you can read the DSM, but the thing to take away is people who have binge eating disorder may or may not be overweight. There may or may not be obesity associated with binge eating disorder. The first client I ever saw who had binge eating disorder had average weight. So more than anything, she spent a lot of time being frustrated because clinicians didn't believe that she had binge eating disorder because their assumption had been that a person with that particular diagnosis would have shown signs of obesity. Anything you want to add to this one, Rebecca?
No.
No.
Fun. I'll talk. It's fun. So avoidant restrictive food intake disorder, eating or feeding disturbance, including but not limited to apparent lack of interest in eating or food, but avoidance based on sensory characteristics of food. So I'm not as knowledgeable on this food disorder, but significant weight loss, nutritional deficiency, dependence on enteral feeding, and interference with psychosocial functioning. Lack of available food. And I don't know if you want to add anything, Dr. TRW.
I do want to ask a question to the audience. Is there anyone here who is familiar with avoidant restrictive food intake disorder, or what we call ARFID? Any familiarity for anybody?
No.
No? ARFID is interesting because this one is in the DSM-5 and it was not in the DSM-4 TR or anyone previous. And one of the things to keep in mind with ARFID is this person does not like something about food. It's texture, it's smell. There's something about it that makes this person avoid taking in food. Do you know the children's author Judy Blume? You familiar with her? Anybody?
Yeah.
She has a character in one of her younger children's books, and he will only eat food that's white. Period. If it's not the right color, he's not eating it, and the only color is white. A person I know will not eat shrimp or lobster because she cannot stand the consistency of the food. She'd sit there and not eat it all because she cannot stand certain qualities and aspects of food. There's certain smells. I know somebody who wouldn't eat salmon or anything that color because the color was just reprehensible. So there's something specific about this kind of food that keeps a person from taking it in. Years ago, there was a gum called Freshen Up, and there are a couple of products like this now. When you bite into it, they squish stuff in your mouth, which kind of makes me feel sick too. Some people that they can't just say, ew, I don't like this gum, let me avoid this. It can be generalized to other things, and their caloric intake can be diminished because they're so disgusted, for lack of a better term, by the qualities of the food.
Yeah, Dr. T, RW, a friend of mine's son, who's a 5-year-old, actually has been diagnosed with this disorder, and they have to go to great lengths in order for him to eat, because he won't eat anything due to texture, and and so he's very malnourished looking because of that, and so he's it's a constant process, and it's been really interesting to learn more about that through her, but it was kind of a wake-up call for me that it's actually quite prevalent.
Yes, more prevalent than one might think. And all eating disorders seem like odd things to people who've not had experience with them on some level. So the idea that somebody won't eat because of whatever reason when food is available can be confounding to people who aren't in that position or situation.
So, Dr. Rush Wilson, is this disorder based on BMI at all? I know it says significant weight loss, but can somebody be at a healthy weight and have ARF?
ARFID, yes. The interesting piece is, and this was a debate we had, I remember once in graduate school, I believe that any of these disorders can be problematic before the low BMI requirements of anorexia nervosa because, for instance, a client of mine was 15 years old, it doesn't matter how old she was. She was about 5'8" and she weighed in excess of 200 pounds. She lost the weight really, really rapidly, engaging in behaviors that are incredibly consistent with anorexia nervosa, but could not have a diagnosis technically because she was still overweight and then normal weight up until a certain point. It was much more difficult to treat her in some ways because the behaviors were so entrenched by the time she actually reached a BMI low enough to have an official diagnosis and her parents actually brought her in for treatment. So yes, ARFID it exists without the BMI requirements. However, a person's weight can drop very low. If it drops very low and the person's avoiding foods and it's not just based on texture or we have a different concern related to how their intake is low, the diagnosis can actually switch from ARFID to anorexia nervosa, which is, in terms of eating disorders, the big deal diagnosis that can actually overpower any other eating or eating disorder diagnosis. You can't have two. So if you meet the criteria for anorexia nervosa and something else, anorexia nervosa is the diagnosis that is given to the client.
Can I add something? I have a question. So I used to work with children on the autism spectrum, and I had a client who would eat barely nothing, and most of her diet consisted of Pediasure because she wouldn't drink anything else, and like unhealthy like candy or so forth. Would this be related to this, or would that just be more of her diagnosis of ASD?
It would depend on the reason for doing it. If there's an avoidance of other foods for some reason, then there could be something in addition to the other diagnoses that that person has. So this can exist with anything but anorexia nervosa.
Okay.
And there's orthorexia nervosa. Would you like me to do that one?
Sure.
Orthorexia nervosa is not actually in the DSM, wasn't in the 4, it's not in the 5, but it is something that's still discussed in eating disorder circles. What it is quite honestly specialized anorexia nervosa, where a person decides what foods are healthy, and then they engage in their diet based on their interpretation of what healthy is. Orthorexia actually means correct appetite. So this person believes that they're eating correctly. One client I had with orthorexia nervosa as a diagnosis would only eat derivatives of chickpeas. So she would eat hummus and chickpeas and hummus, and there's not a whole lot of things on the list. But that was her idea of healthy, and that's what she engaged in eating. I'm going to go through these other ones kind of quickly, but if you're interested, the slides will be available to you. There's also diabulimia nervosa, where people actually manipulate their insulin intake with type 1 diabetes in order to hasten weight loss, which can be fatal. And then a little bit more information about substance use disorders, because there's some conversation and discussion I'd like for us to be able to get to. We know that there's physical dependence that occurs with substance abuse. We know that addiction, which is not, dependence and addiction aren't the terms that are currently being used in the DSM. However, clinically, they are still sometimes used. Addiction can be related to physical dependence of a substance, and that dependence can be accompanied by tolerance and withdrawal. With substance use disorders, we know right now we're in the midst of what is being called an opioid crisis. There's also a heroin emergency, and there's a lot of use of heroin and other drugs that are comorbid and confounded with other substances that intensify the high a person gets, which also intensifies the lethality of the drug. 1 in 15 people who take non-medical prescription medications like pain relievers will ultimately try heroin within a 10-year period. So this is a pretty serious issue. It's also interesting to know that there may be some differences in sex with experiences for drugs in particular. It has been known that women may experience chronic pain with more intensity and greater duration compared to men. And also women sometimes react not just to the sensory feelings, but also the emotional aspects of feeling pain, whereas men are less likely in research to report feeling the emotional consequences of substance use, but more so the physical aspects. See a lot of this. The one thing I want you to be able to take away from this particular slide is that post-traumatic stress disorder is common among people with substance use disorders, be them male, female, any person at all intersex. So what we want to be aware of is sometimes with substance use, and this is also true of eating disorders, the presentation that we see is not the main issue, but it is a life-threatening issue, so it deserves medical and psychiatric attention. Typically, there is something that underlies that presentation. People don't often say, I just want to have an eating disorder, so I'm going to start one, without any kind of underlying issue at all, including ability to cope with different types of stressors. Okay, in part for discussion, and anybody can jump in. If not, I'll just go along with Rebecca and Susie. But with respect to the environment, what things might we want to keep in mind as clinicians when someone presents for help with an eating disorder or with a substance use disorder? Within the environment, how available are food, alcohol, drugs?
I mean, food is everywhere you go. Depending on where you live, drugs might be everywhere you go as well, but food you cannot avoid.
Yes, exactly. It is everywhere. And we can go through fast food restaurants and quickly get food and have it given to us right in our car, have dollar menus, and it's very readily available. And I would say the same is true of substances and alcohol. In Cleveland, I don't know if this is the case in Toronto, I've not seen it up here, but when I'm in Cleveland, there are some convenience stores you can drive through and actually get your alcohol without getting out the car too. So it's pretty easy to access. You going to say something, Rebecca?
No, I'm just agreeing.
Okay.
I know.
So we're looking at access, and then we look at social, genetic, and epigenetic factors. So when we're looking at social pieces, what social factors might play into how somebody engages alcohol or their eating patterns?
just like um, holidays. I know in college,
Go ahead, sorry.
oh, I was just gonna say, I just know in college, like parties, very socially acceptable to drink. Um, and if you weren't, people would constantly hassle you as to why, or same with food, kind of. So,
Anybody else?
Well, for me, I think of like environmental risk factors in the sense that you know, society really plays a role into the expectations of how we're supposed to be, what we're supposed to do, how we're supposed to act, and also that I think that also entails what we eat and what we drink.
Anybody else? No one else has experience with the social pressures related to food or alcohol.
Well, just how we look like, whether it's being cool or just as far as like the ideal image.
Exactly. I've seen people, you know, at parties where somebody else just walked up and put a drink in their hand. As that was, you know, that wasn't even an invitation. That was kind of a command. Or a person who is a colleague of mine who was a licensed clinician. This used to make me really irritated with her. She liked watching other people eat, but didn't eat herself in a way that was healthy. So she would take things off of her plate and put them on yours, which really made me angry. But what she was really doing was attempting to get the food off of her plate so that people didn't pay attention to how little she was actually consuming. So we look at like genetic and social and epigenetic factors. This one is a little more confounding. We look at genetic predispositions toward alcohol and toward eating disorders and their predispositions. So there might be a gene that is influenced by the environment that allows for an eating disorder to continue for generations. That environmental change that we call a stress, the biology is called the diathesis, and then that environmental piece is called the stress. That's the epigenetics of eating disorders. And we know that now in substance use disorders as well, that epigenetic changes can be transmitted genetically for up to 3 generations. At least that's what the current research is supporting in part. And there's still so much out there to be considered and learned, but the methylation of a gene or how that gene is expressed continues to be studied because there's still so much new information out there. But it is concerning and alarming that these environmental changes and experiences that we have can change how a gene is expressed. So if genes have on and off switches, we can have environmental situations that can be carcinogens or toxins or stressors or abuse or trauma that actually flip on or flip off the switch for how a particular gene is expressed. So for instance, if we have identical twins who are reared together, one of them may go on to be very healthy and the other one might have cardiac issues, in part because of how certain parts of their genome are activated and expressed because of methylation. Does that make sense? You following me? Can I move forward? You're also silent.
I just wanted to bring up a point that Allison put in the chat, and it says that she grew up in an environment that was a disordered eating environment, and it wasn't until after a certain time in her life that she her disorder became full blown. So I just wanted to call attention to that.
Yes, thank you. That too. Okay. I think we talked a lot about this, the genetic and epigenetic pieces, peer pressure, predispositions. Yes. Here's a slide that I really did want to talk about with all of you. The similarities between eating disorders and substance abuse disorders. These are things that I think counselors really do need to be aware of. Both of them can result in an altered mental state. There are some people who actually, for lack of any clinical or better terms, actually enjoy the feeling of purging. The feeling of being too full is intolerable for some people, so that purge is a release. And then I think most of us are aware of why a person might enjoy the altered state of substance abuse. with anorexia nervosa as well, there are people who actually enjoy at some point the feeling of emptiness more psychologically than physically. They may not like the physical void and the pain that may come along with not eating, but the idea in their minds that they are clean is useful and helpful in their minds as they continue on what some consider a journey with eating disorders. They both may be conceptualized as intentional, and while eating disorders and substance use disorders do involve the active engagement of behaviors by the person who has the diagnosis, at a certain point they may feel like they've lost control over their behavior and they're continuing in these patterns because they feel like they don't have another choice. Weight issues, fear of weight gain are not prominent in substance use and abuse, but they can be factors in substance use. There are some people who actually engage in particular substances to help reduce their weight. Back in the 90s, I think it was, when Mary Kate and Ashley Olsen were pretty popular. I think it was Mary Kate Olsen actually was using cocaine allegedly to control her weight. Cravings patterns of compulsive use are prominent in both. It's possibly related to the similarities in the neural systems that we experience with eating disorders and with substance use disorders, but it's not clearly understood. Often people with either diagnosis have a trauma history or some traumatic event with which they are coping. They both may have numbing qualities that can allow them to escape emotional and psychological pain. Both have qualities of control involved or their perception of control. Both may be, a person may engage in both beyond what they plan to do. So a person may think, well, I'm going to just use this quantity of a drug and then I'm done with it. And they can't just stop. Or a person may think, I'm going to just binge and purge and I'm going to stop. I can stop whenever I want to until they realize they can't just stop as easily. Talked about trauma already. They both may have a genetic component. They both have intense direct activation of the reward system, the neural reward system in the brain. They both may be related to secrecy. I want to come back to that one. They both may have a level of social encouragement until a line is crossed. So a person might be celebrated for how much they drink and how much they can drink, or a person might be celebrated for how thin they're getting and how they have so much control until they cross a line and other people deem to be unacceptable socially, in which case all of the support they were receiving may turn around and be considered non-support. They can both be dangerous and lethal, and intensive treatment may be needed to support either one. But back to the idea of secrecy. What do I mean by that? Any ideas? Anybody in the audience?
Well, I mean, I could share just because I kind of remember when I was, the secrecy stuff, with eating disorders anyway, with the hiding food tactics, kind of like avoiding different situations where food wasn't in, so where food was like around, just like avoiding those situations, yeah, stuff like that. And I know that substance abuse can be the same, especially with like alcoholism and stuff, a lot of sneaking around, drinking, alone, etc.
And with other drugs as well, there often is diminished, if there ever was any pride attached to it, it diminishes over the course of time when a person realizes that they cannot engage in sober behavior. They can't just stop whenever they want to. And there can be shame attached to that, which facilitates the secrecy. So when you are treating a client, and this also can be associated with people who self-injure, even though that's not the topic, that falls into this category too. Sometimes when we as counselors are treating people who have these particular diagnoses and presentations, it's important to create an environment of trust so that your client will actually tell you what it is that they're doing. Because if they don't tell you, there really is not a lot of, there aren't a lot of ways to find out. Okay, and with coping, let's see, with coping, what I want you to take away from this is sometimes our culture, sometimes our family, sometimes our lives present situations that are traumatic or disturbing. Eating disorders and substance use disorders are often ways that people cope with traumas that they perceive to be traumatic or with issues that they perceive to be traumatic. We can't identify what a trauma is for someone else always. Sometimes we can look at a situation and identify it as something that would be traumatic for you or for me, but someone else may have something that seems very benign that is actually quite significant for them. It requires that they have coping mechanisms in place. Treatment options, won't spend a lot of time on this either because I want to make sure we get through all of the slides, but the treatment is the standard treatment that you would expect for eating disorders or substance use disorders. So people go into different rehab facilities, and within those facilities, there are multiple different disciplinary methods for treatment. With this, though, we have to be careful with medication prescriptions. Why might that be for anybody in the audience? I know you're still there. I can see how many people are here. So anybody have any idea why medication prescription might be risky and has to be done with care?
Or if they have underlying health problems related to the eating disorder, or if they have a comorbid substance use disorder?
Yes, both of those things could be true. And what about with eating disorders and medication? What other thing might we need to keep in mind?
Sometimes you need to take medication with food, so that way it's absorbed and fully absorbed. So it might be difficult for those who don't want to eat it with food.
Exactly. I've had clients ask before the calorie count on their medication. So this person is constantly thinking about how this will affect their body. Some medications cause weight gain. With substance use, pairing certain medications with the substance of choice could lead to disastrous consequences as well. So the physician or whoever the prescribing clinician happens to be has to be very careful with how to prescribe. And also, if a person is taking fat-soluble medications and they're underweight, the medication may react in a way other than expected. Careful with that.
Okay, I'm just going to kind of breeze through this so we can get to the other slides, and a lot of it has already been mentioned. But the environmental risk factors are many, as Dr. Rush-Wilson and Rebecca alluded to. There's an influence of immediacy now more than ever, and accessibility as far as a prevalent role that social media plays in our society today. Like, for me, I often think of these photographic filters that are used to help portray an image of perfection, either by like narrowing someone's facial figures or a certain selected body whether it's body part, so it fits into more of a mold of a societal expectation. There's also this peer pressure of condition of cause of being harshly judged, shamed, blamed, or criticized. And so there's this overwhelming need to fit in and belong, because I think we all want to belong. There's the sensation-seeking behaviors that, everyone wants to discover novel and thrilling experiences. And they don't really put much consideration into the consequences that might entail. There's trauma, as Dr. Rush-Wilson mentioned, and there's quite a high prevalence rates of abuse and sexual abuse. And the restriction of food, binge purge cycles, binge drinking can all be a way for an individual to try to gain control and find a sense of release from the pain and the feelings of hopelessness.
A little on self-care and eating disorders. So one of my favorite books that really helped me through the process and was actually recommended to me by my therapist at the time is Life Without Ed by Jenny Schaefer and her psychotherapist Tom Rutledge, and it describes her eating disorder and her journey with recovery. And I really liked her psychotherapist helping her imagine her eating disorder as a separate person than herself. So doing role play conversations, talking to her eating disorder and recognizing when she called him Ed, when Ed was talking to her, and how to talk back against him and not let him overpower her. Also, detoxing from social media can be great, especially because social media is it's everywhere now, and we all can admit that, well, I know I can admit anyway that sometimes you can just be into it for so long and constantly judging yourself by the people around you, and everything can be really dangerous to those who have that mentality. Practicing mindfulness is always good. Seeking nutritional advice from a professional, which usually the individual won't seek out themselves, but hopefully from they're seeing a doctor or anything, it's more than likely they'll be recommended to a nutritionist. And talking it out with friends and family as much as possible, or group counseling, etc.
And piggybacking on that social influences and social media comment that Rebecca made, social media is very prevalent. It influences our behavioral and our visual standards. There are some pro-drug sites and some anemia sites. Is anybody familiar with those? Any of you in the audience? No one?
Heard of them.
You have heard of them. Okay. Both of them, the pro-drug and the anemia sites?
Mm-hmm.
So there are places where, I'm sorry?
Blue light, I think. I don't know.
There are a lot of them. Yeah, unfortunately, there are a lot of them. And these are sites where you can go to actually get tips on how to perfect your pathology, essentially. So people are, unfortunately, on the anemia sites giving things called inspiration tips. And I have some pictures here in this collage of the types of pictures that you can get, especially the one where you can see the person's vertebrae, the spinal column. Those types of things are thought to be inspirational pictures for people who want to achieve a greater degree of illness with their eating disorder. And then there are also some pro-drug sites. The thing that was interesting in researching this, which I allowed myself to go to some of these sites, was the fail is very different at an anemia site than it is at a pro-drug site. And pro-drug is the actual name that was given to the body of sites, not a name that I made up. One seemed like, well, the pro-drug sites, the pro-substance sites, it's not a big deal, it's just to relax, it's fun, it's cool, blah, blah, blah. With the anemia sites, there was more of an urgency where you have to do this, if your life depends on you doing this. Both of those energies appeal to a person who would go to that type of site seeking information on how to either find places where they can illegally and illicitly use substances, or ways where they can hide their eating pathologies from people around them.
So I wanted to share really fast some interesting information I found with alcoholism being related to bulimia nervosa a bit. In my journey of finding out why my eating disorder happened, more looking at there's alcoholism in my family, and I was looking if there was any correlation between that, and I found in twin studies there's a genetic correlation between alcohol dependence and binge eating, and alcohol dependence and compensatory behavior, and binge eating and compensatory behavior. And the two disorders can be transmitted independently in families. So say one individual have alcoholism and the other one may have a binge eating disorder. And I also found that an alcoholic father's parenting style could be authoritative and erratic due to the genetic predisposition, but children can be differentially influenced by this parenting style, depending on how genetically predisposed they are. So one may be more vulnerable for the disorder or for an eating disorder than the other one. Also, early maturation in individuals going through puberty really early can increase negative attraction from opposite sex peers and put them in an environment where access to alcohol is common. So the two disorders can be very related to each other, and I hope to do more research on that and be able to talk more about it eventually. But I know we only have 4 minutes.
Rebecca, you actually have less than that. If you could kind of wrap it up in the next 2 minutes, that would
I'm
be
done.
great.
Yeah, we're done. That was it. We've covered everything else. So does anyone have any questions for us in these last 3 minutes or so?
I have like 17 questions, but I'll ask one quickly. So with clients who have comorbid eating and substance use disorders, I've noticed sometimes that eating issues might intensify when they're no longer using substances. Why is that?
Well, largely because the eating and the substance can both be seen as coping skills. And when one is taken away, the other one is intensified. That can actually work in the other direction as well, depending on which one is treated first. Also, when someone's substance use has depleted, they may feel like they need more control over their life and their experience, and often that eating piece is indicative of the need of control or the intensified eating.
Thank you.
You're welcome. One last question, or are we done? Okay. Well, thank you for your time. If you have any questions for any of us, please feel free to contact us. Thank you, Dr. Hudson.
Thank you, Dr. Rush-Wilson.
Thank
you so much.
Thank you,
That was
Rebecca.
great.
Thank you, Susie. It was a wonderful presentation.
Great job.
Yeah.
Okay, so next we'll have the importance of effective supervision for new professionals. So Dr. Crowley and one of our alumnus, Melissa Seitz, is here as well, and she'll be presenting with Dr. Crowley. Dr. Crowley, are you here?
Yes, I am.
All right, perfect. All right, I'm going to stop the recording.